Hello and good afternoon. So, if you have not heard about watching me at 1.5 or even 2 times the speed, I do have that on the email so that you can watch me faster. A lot of my PowerPoints or education is very slow and methodical on purpose so that those that need to understand it or have a more difficult time understanding it, or my brain is slow in trying to process that information because I don't read off of a script and I'm trying to speak directly to each one of you individually. Put me on 1.5 speed or put me on 2 speed and get this done and over with a little faster. This is not a requirement. You can watch this if you want. It will actually be on the email. Watch it if you want. This is just describing one little thing that I did for you guys today. I spent all day working on it. It's now 6:30 at night. Time for my dinner, and I wanted to record this for you because I really wanted you to be able to have it tomorrow to be able to utilize it. So I'll go really fast, as fast as I can, but then again, bump my speed up if you need to. So for those that are familiar with this sheet, I give it out during new hire orientation. It has the hospitalization recap on the first 2 pages. We went over that in depth during our discharge education yesterday. It was only yesterday for me, but for you it might have been longer. So that being said, I'm not going to reiterate this. Go back and watch your discharge video or read over your HPI. Your history of present illness is where we're going to be stuck today. In a snippet, something that I am giving to you and explaining how to use. It's nothing that you're going to be responsible for learning, using. You never have to use it if you don't want to. I created this form to help remind you of some things that need to be put in your HPI. A lot of people are having difficulty documenting on an HPI. Some responses I've heard is, I've never done it this way. Doctors don't do it this way. I've been a nurse practitioner for 8 years or 10 years. I've never had to do it this way. Remember that in 2023, CMS came out with brand new guidelines. So if you've been a nurse practitioner for longer than that, there are changes on a regular basis. So as I'm going through some of these things, it's to make a more robust HPI. So I have seen an HPI that uses the age snippet, which says this is a however many year old male patient with a primary diagnosis of pelvic fracture. Then they've clicked the admit snippet that says I've done a comprehensive assessment. And then their only one statement is patient lying in bed. So as far as the history of present illness, what's going on today, the extent of the note says patient lying in bed. So we've got the discussion about how old the patient is and their diagnosis, and we've got the discussion that I've done a whole bunch of stuff, but my proof is saying they're lying in bed. So this is trying to beef up your note and actually write what you did for the patient. So we'll be going over this in detail. If it's an acute issue, then we would use old carts, and it's easy enough. But those long-term care patients that we're seeing month after month, and they present as stable, why do you keep seeing them? Well, out of medical necessity. So we're going to talk about that today. The next 2 pages, page 2, 3, 4, 5, and 6, are going to be your physical exam. So on your physical exam under True RCM, it's a benign exam. Nothing's wrong with the patient. When you use the initial template, it needs to be adjusted, edited, fixed, completed. There's a whole bunch of snippets out there that you can utilize. But if you don't see something and you can't remember the wording or how you could do it, pull this up and utilize this if it helps you. And then this last 2 pages, page 7 and 8, this is your assessment and plan. And so it talks about what you're going to do and not do. We're going to avoid vague statements like if indicated, as indicated, monitor as per usual, labs as per usual. So we're going to avoid that. And then because this is for the assessment number 2, 3, 4, and forward, not your first initial, but for follow-up assessments or routine visits, You only need 3 to 4 assessment and plans. So I bet you thought I was going to say do one on everything. No, 3 to 4. Put the worst, the highest priority, the most critical, the one with the most changes. Those go on top. So can you use more than 4? Absolutely. You can actually, the first 12 fit on the billing record. However, you only need to do 4. Now, if it's an acute exacerbation, we can do 1. If you've got a patient that's critical with congestive heart failure and we're looking about transferring them out, you really only need to use 1. But all the rest, 3 to 4 on the assessment and plan. That being said, I will send you a copy of that. Now, on to the fun stuff. On the left is what your true RCM is going to look like. And it is a snippet, a single snippet, and it'll pull all of that information down. On the right is a reference guide that I've made for you guys with the answers to that. Now, it doesn't have to be the exact answer. You can free type this as well. But this is going to be under a routine visit, and it actually has the age part of the snippet in it as well. This is a blank-year-old blank patient with a primary diagnosis of blank. Now, I guess you're wondering why I'm doing that. Well, because if we put them in parentheses or put ideas or put stable, not stable, unstable, hypotensive, hypertensive, normotensive, seizure, no seizure, you guys just leave that template in there. So the lines are to remind you to fill them out. So the lines are there, use them. So I have given you examples of how you can document. The reason for the visit today, my suggestion is you either print this, it's 4 pages, front and back it, staple it, you've got 2 pages, it's sitting on your desk. My preference would be to save it to the desktop, and then I would open it, and I would, regardless of how big my screen is, it could be a laptop, put my true RCM on the left, or right, either one, and then put this quick guide, and you'd only have to use it for this HPI snippet. And then you could either minimize it or close it out, either one. But that being said, if you've got it on your desk and you're doing putting it into True RCM, you're going to have to type it, hand type it. If you're using this side by side, you can actually copy and paste it. Therefore, I'm going to go through a visit with you. It's going to be a very fast-paced visit that we're going to put together, and then I'm going to show you what it's going to look like at the end. So the reason for the visit today, and I do, before you start using this, just at least go through this quick reference guideline so that you can see what your choices are, because there's some that are like sick and some that the patient's really stable. So routine chronic disease, monitoring response to treatment. So you started them on a new blood pressure medication 3 days ago, antibiotic 3 days ago, whatever, and you're doing a monitoring response to treatment. This could even be your psych NP follow-up visit. So you had psych NP in the building 3 days ago, and now you're following up with them, or even wound care. So monitoring response, following up after recent decline. Maybe they came back from the hospital and they just haven't bumped back. Maybe this is where you're going to utilize this. Ongoing monitoring of chronic conditions. So it says routine chronic disease follow-up. Disease, in my opinion, is a disease. Chronic conditions. And you're just going to take this. You can actually do that right over the line and then put that there. Okay, so the clinical rationale for ongoing support, I'm going to go through. You can read again. Monitoring a chronic condition for stability and early detection of decline. So I'm going to put that right here. Effects on ADLs. Oh, sorry. Current symptoms or findings supporting diagnosis, monitoring chronic condition for stability. Effects on ADLs. Requires assistance with transfers. Now here's where it gets a little bit weird. You don't have to put all of this stuff in here. So if you know if they're limited or extensive or partial, that is for the nurses to document. So as long as they've maintained their baseline function, or they need assistance with transfers or requiring queuing because they've had 4 falls in a row, it doesn't matter. But you don't have to put anything like limited, extensive, that kind of thing. So sleep, they're sleeping through the night, or no sleep complaints. Those are two of the normal ones. Or intermittent awakenings, fragmented, or difficulty initiating sleep. So that you've got an abnormal, so you're going to put an intervention in place. So we know that insomnia is going to be one of our assessment and plans below, and we're going to do something about it. So we should be able to initiate melatonin, magnesium. We should be able to put something in place or collaborate with the PMHNP. When the PMHNP says, I'll be there in 3 days or I'll be there on Monday, just say, what would you like to start them on now so that they can sleep? Because I don't want them to be without sleep for 3 days. So go ahead and get that information out of them. I'm just going to put that no complaints of sleep are reported. The appetite, consuming most meals, reduced appetite noted. Variable intake requires encouragement, and then weight status. So weight is stable. So if their weight is highlighted in red in the computer, their weight isn't stable. If they've been the same weight for 1 month, but they have significant weight change over 90 or 180 days, then it's not stable weight. You can write in parentheses or as additional information, weight stable this month, continues to have significant weight loss over the past 90 or 180 days. Gradual weight loss noted, fancy word here, insidious. So if you have insidious weight loss, so you have a pound a week, but you've got a 180 pound patient, so they've lost 1 to 2 pounds every week for the last 6 to 8 weeks because they're not eating well, it's not an edema thing. We can say that's gradual because it's not going to trigger for significant weight loss. So I'm just going to put here the weight is stable, but there are other things that you can put. Mood is stable, anxiety, depressed mood fluctuating, behavioral symptoms controlled. So if I've got them on a psych med, or if somebody's got them on a psych med, I might choose that one, behavioral symptoms controlled versus stable. And then psychotropic medication tolerance. So let's say they have no psychotropic medication. Delete that whole entire row out. Just delete it out. It's not applicable. Psychotropic, if they're doing okay with psychotropic medication. So they're on an antidepressant and they still have a depressed mood. If their mood is fluctuating because they have bipolar. If they've got anxiety symptoms that are controlled. So let's put that on there. Because they're on Xanax and Valium and clonazepam, etc. So participates in therapy. There is one that has not currently participating in therapy. If you don't know, because it's a long-term care patient and you don't know if they're on Part B or if they're getting therapy, A, I would ask because I think that's very important. But B, I would just right here, response to current treatment. Is that the one? Oh, therapy, sorry. Participates in therapy. I did that because I readjusted the thing. So I would say actively participates or participates within therapy or not currently participating in therapy. Or you can take the whole entire thing out. It does not have to be part of your statement. So response to current treatment or monitoring plan. So tolerating medications without adverse effects. So your chief complaint is congestive heart failure, tolerating medications without adverse effect. You can write something to the effect of continues on diuretic therapy, 2+ bilateral lower extremity edema noted. So this is not made to be a blanket template with blanket answers and then we just fill in the blanks and call it a day. We actually have to put what's relevant to the patient. So current response to treatment or monitoring plan would be continues on diuretics. So many times I have written it continues on Lexapro instead of Celexa, or continues on Norvasc instead of whatever. It's easier to just say continues on diuretics or continues on antihypertensives continues on psychotropics. So continues on diuretics with 2 plus bilateral lower extremity edema. And then I would put no shortness of breath, dyspnea noted on room air. So that's just me responding to the treatment. Again, this is made to help you and to minimize what you're documenting, not to replace what we're documenting. So today, what did we do? If you did not review medications, delete that out of there. Did you review medications today? If you didn't, please don't put that you did. Because the worst thing that could be on there is that you reviewed medications and that you didn't make any changes, and then you realize the patient's blood pressure is 86/40. So if you didn't review the medications, don't look at that. Don't put that in there. Just delete that whole thing. Recent events, falls, hospitalizations, behavior, decline, functional decline. If there's no recent events, delete that part out of the snippet. Patient denies new complaints, reports fatigue, reports poor sleep, reports pain improvement, or if the patient cannot respond, delete that out of there. If they're not alert and oriented, or they have they're unresponsive, or they have no communication, don't put that on there. Staff reports no new complaints, no acute concerns, decreased appetite, increased confusion, participation in therapy. So we took the therapy out. So there that is. New findings since last visit. No new findings since last visit. New symptoms reported since last evaluation. Well, we did, because up above we saw that the patient wasn't sleeping very well, and we're going to do something about that. So if you did do that, you could put that on there. Again, this note doesn't make sense because right up above I deleted the patient, and then I put the nurse, staff reports no new concerns. But again, I'm just making this up as we go. Baseline status compared to prior, they're at baseline, no significant changes, improvement or mild decline. So if you've got a mild decline, you want to state why, because any adverse or untoward things we want to explain. If they're not sleeping, we want to explain that. We want to pursue that. If their appetite isn't good, we want to explain that. We want to pursue that. So we've got our snippet here. It's all the way done now. Now, I want a lot more than just this. Like, this is to help you get through it. No sleep complaints reported. Sleeping 6 to 8 hours most nights. So easy enough for you to add that. So consuming most meals, appetite, good. So again, it's just to help you. It's a freebie. So monthly HPI rule. So each month, the visit must include one new observation, a comparison to the prior visit, or statement of ongoing needs. So if you changed their antihypertensive last week, please follow up, and that's going to be your chief complaint. Follow up on medication changes. And so put that on there. But I almost want to say monthly / last visit HPI rule, because we want to make sure that this visit is medically necessary. So if you know how to do this, perfect, you're awesome. If you do not, then please contact myself or any of the other nurse practitioners, and we can go through this. I may have 2 Zoom calls where I can explain it, but this is what I did with my note. I took my note, which I did this before. I took my note, and now this is my note. So the patient was seen for routine chronic disease follow-up and ongoing monitoring of established conditions to support stability and allow early identification of potential decline. At this time, the patient's clinically stable, no significant changes from prior evaluation. Functional status remains at baseline, with the patient maintaining usual participation in daily activities. Sleep patterns are stable, no complaints, appetite adequate. Patient consumes most meals, weight is stable, mood is stable, and the patient continues to be followed by psychiatric services with behavioral symptoms reported as controlled and psychotropic medications tolerated without adverse effects. I feel bad for those that are listening to this at 2 plus or 2 times. Current medications were reviewed during today's visit. Regimen assessed for continued tolerance and effectiveness. No new complaints. Staff says no new concerns. No changes in condition. No new findings have been identified. The patient continues to tolerate the current treatment and monitoring plan without evidence and complication of adverse effects. So you can see how I just took that blanket snippet, filled it in, and then created my HPI. So that's really important for you guys when you're trying to put together an HPI and you can't figure out what you're going to write because the patient is stable and there's been no changes. I've given you multiple options on this template that you can utilize. And if you just put it to your desktop and break True RCM and this template in half just for this first part of the HPI, I think it would be amazing, and your HPIs would be robust, and it would look different. You would feel different. Your notes would come out better. Your audits would come out better. For those that are already doing something this robust, maybe you could utilize this in different ways and just copy the parts that you are forgetting, or just be reminded. And for those that don't want to use it or didn't watch the video, they're missing out. That being said, I hope you enjoy your evening or morning whenever you're watching this. I hope this helped. If you have any questions, reach out and let me know, or Tatiana know. We're willing to help you. But I think this is a great little snippet tool that you guys can use that will fill up your entire HPI if you utilize it right and put the required information. I've given you the snippet, which is 30% of your note, your HPI. I've given you the quick reference, which is another 30% of that fill up. And now all you're doing is adding stuff like CHF and diuretics and antihypertensives and that kind of stuff. So hoping it's making it super easy for you. Hoping you have an amazing night or day, and I'll talk to you soon.